Vermont Vital Signs is co-produced by Vermont Public Television and Fletcher Allen Healthcare in alliance with the University of Vermont. Fletcher Allen Healthcare, where knowledge is your best medicine.
We are hearing more and more about incontinence, thanks in part to TV ads for drugs to treat the problem. It is estimated that about 20 million Americans suffer from involuntary urine leakage, and the number is likely higher because many people simply don't report the problem because they're embarrassed or think that nothing can be done to help them. Our panelists are well versed in dealing with incontinence of all types. Doctors Richard Kirshen and Julie Lacombe are associated with the Continence Center at Fletcher Allen Healthcare. And Jane Kaufman is the founder of Phoenix Physical Therapy in South Burlington, a practice devoted to treating patients with this problem. Welcome to you all. Thanks for coming in. Richard, why don't we just start with you to define what an incontinence is and you know, some of the common types.
Sure thing, Fran. First of all, thank you for having us on the program. We're really happy to be here, and we really want to get people out of the bathroom and out enjoying their lives. So,
Right.
Incontinence is sort of a general term, and really it can be broken down into several different types. The interesting thing is that many people will suffer from more than one type. On a basic level, there are two major causes of incontinence are stress incontinence, which is loss of urine, most often in females, associated with coughing, sneezing, physical activity or exertion where urine's kind of pushed right out of the bladder, usually in short bursts. The other main type of incontinence is called urgency incontinence, and that affects both men and women and is associated with a very strong desire to empty the bladder. It's just when you feel like you just can't get to the bathroom on time, and then you'll often leak before you get there. It's sort of the feeling that most people get when they're pulling up in their car, fumbling for their keys. They know they're going to be near the bathroom soon, and they just can't get there. That's urgent incontinence. And the hard thing is that many people will suffer from a combination of the two, which is called mixed incontinence. And as you can imagine, those patients are usually the wettest.
Okay. And Julie, what are some common causes of incontinence?
Common causes of incontinence depends, of course, on the type of incontinence, but if we're talking about stress incontinence, for example, when you cough, laugh, or sneeze, one of the biggest risk factors is childbirth. Genetics plays a major component in that, and that's something we don't have any control over. Menopause, patients who have stress incontinence certainly can have it before menopause, but after menopause, the symptoms seem to be more prevalent. Jobs with heavy lifting, improper lifting of heavy items, patients who have perhaps chronic cough, smokers. There's a multitude of risk factors. It's basically any risk factor the risk factors are basically those that damage the structural components around the urethra.
Okay. And then also it seems that some sorts of surgery or prostate can also create some problems.
Yeah, I'll just comment on the men. So stress incontinence, as I said, is most common in females, but it can occur in men. And when stress incontinence occurs in men, and when, again, I'll just redefine stress incontinence, that's sort of passive leakage of urine. If you cough, move, lift something,
laugh,
walk,
I like that laughter.
Laugh, anything like that, when that causes leakage just to spill out of the urethra. When you think about it, from an anatomic standpoint, men and women are very similar. There's a bladder, which is a reservoir that has to hold the urine in, and then there's a urethra sitting under the bladder that normally stays closed when you don't want to urinate, and when it's time to urinate, it opens up and lets the urine come out. So during those periods of storage, when you're not planning on voiding, the urethral pressure is higher than the bladder pressure. So in a female that has stress incontinence, usually maybe as a result of multiple pregnancies, labors, deliveries, the urethra is weakened. And so when they cough with a relatively full bladder, the urethra being weakened opens up, allows the urine to come out. Now in a man, the reason why I'm getting to this is that men generally, because they have a prostate, don't have that problem unless maybe they either have a neurologic disease, like a spinal cord injury that could cause weakness in the urethra, or maybe they've had surgery like a prostatectomy to relieve obstruction or for cancer, and those people can very commonly suffer from stress incontinence. Urge incontinence in men like you were alluding to, often will result in older men after they've developed what's called BPH, or a benign prostatic hypertrophy, an enlarged prostate that blocks the bladder and then irritates it into spasming.
And Jane, I imagine you work with all types. Is this mainly something that does happen when we age, or what is the span, or is there something we should think about this as something that will happen or not?
Well, first of all, incontinence is not a normal part of aging, and within our practice we see patients that are anywhere from 5 years old to 95 years old. About a third of our population is men, and most of the women tend to be anywhere from 30 to 70 years old. What's interesting is there is a statistic from the National Association for Continence that says it takes women 6.5 years to finally bring up the problem of incontinence to their physician. So it takes a while for people to finally mention it.
Do they feel that they should have learned their Kegels when they got pregnant, or what makes them hesitate? Just the embarrassment?
I think the embarrassment and the fact that they think, well, I've had 3 children, so therefore it's a normal part of aging. I guess, you know, my mother had it, my grandmother had it, I need to just live with this. And that's not the case at all. There's so much that's out there that can help someone get over that problem. And many people are embarrassed. I'm sure you see that in the clinic, that they don't want to talk about it. And when they finally agree that, all right, I'm going to go through treatment, they're relieved that there's something they can do that's relatively simple and will make a world of difference for them.
So let's talk about what they can do, because it sounds like there are indeed treatments. So what kind of, if they come through your doors, what kind of, or even their own physician, what kind of tests and treatments can we expect, Julie?
Well, I think a thorough history of the types of incontinence that they're experiencing, and a physical exam is very important. We would always check a urinalysis to make sure that they don't have an infection, which is a common cause of urinary incontinence and very simple to fix. We would also make sure that they're emptying their bladder adequately, which would, you know, the inability to empty the bladder adequately is a sign of maybe another problem going on, and you definitely want to be able to identify what is causing the incontinence. Once you get to that point, you can guide the treatment, because each different type of incontinence can have a different treatment option that would work better than another. One may work better, for example, with a course of physical therapy, and with or without medication. Another one may work better doing something a little simpler. Not every patient who has incontinence must have surgery, and I think that's important. There are many patients with incontinence who have surgery, but it's not a, that's sort of at the one end of the spectrum. There's a spectrum of treatment options, and they can be minimally invasive.
I think what I would add to that is that our approach, at least at the Continence Center, and I think the correct approach is to not treat patients in a vacuum. First of all, you don't have to get one treatment or the other. It really has to be a joint partnership between the patient and us. I mean, there are going to be things that the patient can do at home without us needing to do anything that can make them a lot better. And we often have patients come into my office complaining of, you know, urinary frequency and urge incontinence, and you know, they have the 60-ounce big gulp coffee in front of them, and they'll be, I don't know, I'm in the bathroom every 10 minutes and I can't figure it out. And it's not because they just don't realize it, because you develop these habits in life that they're part of your daily routine, and they may not have caused a problem or not have been bothersome to you for years, and then suddenly you have a problem, and you can't just look back and say, what is it that I do that's wrong? So sometimes it takes us to point it out to them, and what we'll often do is give them a diary. They'll record what they're drinking during the day, and they'll measure the amount they're going throughout the day. And it sounds like a futile exercise, but believe it or not, patients come back a week later with this grid, and they say, you know, I had no idea I was drinking so much. And
or
all
the green tea was
caffeinated. Exactly.
Uh-huh.
And so there are certainly behavioral things that patients can do. Aside from that, there are, of course, pelvic floor exercises they can do at home, or if they need the assistance of a specialist, they can see a great group like Jane's in order to learn how to strengthen their pelvic floor. And if it comes to needing surgery, surgery alone is not going to cure every problem, even if it's successful surgery. So the patient is still going to have to participate and do these behavioral changes in order to get a real success.
Sure.
A lot of the symptoms that someone will come in with will be layers that they've created over time. A woman might have some simple stress incontinence when she sneezes and coughs, and after a while she might say, maybe I better wear a pad. just in case I leak. And then it's, well, I think I'll go to the bathroom when I get to the grocery store, when I leave the grocery store, when I get home from the grocery store. And suddenly, over time, they've created issues of frequency, needing to use the toilet more than would be normal, or they've put a pad on, or after a while they start to avoid going out and socializing with friends because they're afraid they're going to leak. And it started perhaps as a simple, less extensive problem, but because they've been afraid of leaking, they've added these little layers and these little precautions to the problem.
And there are habits that just exacerbate the problem.
And therefore, if you can change those behaviors, you can make a world of difference in that.
Okay, just to find out more about one of these aspects, a physical therapy aspect, we are going to visit Phoenix Physical Therapy and talk with one of Jane Kaufman's colleagues.
Phoenix Physical Therapy, which is located in South Burlington, is a specialty clinic physical therapy for patients with incontinence. And that can be urinary or fecal incontinence. When a patient is referred, they often have a dysfunction with their muscle, and we pride ourselves in teaching them how to use that muscle. We really see a lot of female patients here. However, it's not uncommon for about a third of the caseload to be men. And on a rare occasion, we're working with children who have a dysfunction. When a patient comes in to learn about their problem, we quantify the problem through a verbal questionnaire. And then we take some time to explain the location of their muscle and the relationship of this muscle with the bowel or bladder. In order for them to see what their muscle is doing at rest and during a muscle contraction, we use something called surface EMG biofeedback. And that's when a piece of equipment helps to pick up muscle activity at the location of their pelvic floor and then transform that information to a graph. And we are looking at a laptop and a software program that can depict their muscle activity. And we help them with controlling this muscle through repeated education and exercises. It's very similar to when you go to the gym. You may read or be told what the exercise is that you should be doing, but unless you have proper posture and maybe the visual feedback from a mirror, you aren't getting all that you could get out of the exercise. Well, with biofeedback, you can use your eyes and or your ears, if we use the auditory component, to help them learn. And we really need to teach them everything they have to know about using their muscle so that they can be independent with a home program and so that their function will improve. We work with patients anywhere from 3 weeks to 3 months, and it seems when we have our final reevaluation, we discuss with them some sort of a maintenance program. I find helping patients with urinary or fecal incontinence is rewarding because this is a quality of life issue. And when you can help them regain control, they are confident to go to work or go out in public and remain active rather than isolate themselves socially. So it's very rewarding to help them recover.
So Dee Dee makes it clear that quality of life issues is very much a part of your work. In a way, I'd like to just talk about that. You know, confidence in social situations is so important here. How do you work to restore that trust, that comfort? And why don't we start with you, Jane?
The first thing is education. When you give someone the tools to understand what's wrong, it gives them much more power to know they have some ability to start to control the problem. And we work on making sure that they have successful situations, and then they can build upon each one of those. So perhaps if someone really wants to get rid of a pad that they wear all the time, we might start with not wearing the pad in the evening or at bedtime. Let them get success with that and then try a more difficult situation. And it's as they develop their layers, we're taking those layers away bit by bit, but when they're ready to handle that extra confidence.
One step at a time, but doable.
Exactly. Absolutely.
Any other thoughts? I mean, you're talking about very intimate things with people. Do you find yourself trying to dig just a little bit deeper because this is difficult for people to talk about?
I think you can generally read that as soon as you get into the room. I walk in to see a new patient that I maybe haven't met before that has incontinence, and obviously people come in all different shapes and sizes, but when you have the person that's kind of looking down at the floor and you ask them why they were sent here and they're very hesitant to tell you, even when they know they've come to a specialist for that problem, this is someone you're really going to sit down and hold their hand, and you're going to say, listen, this is something you're not alone in. Not only am I here to help you, but I've just seen, 30 people today with exactly your problem, and I'm sure a lot of your friends have the same problem. So what you try to do is let them know that they're not an outcast, that millions of people across the country have this problem,